Hello, and welcome to another episode of MCREG International on the Go. I'm pleased to be joined by Dr. Gregory Furman. Greg, thank you very much for being here.
Thanks, Brian. So the predominant question we're going to answer in this segment is how are the DOACs used and how they represent an advantage perhaps over current standard therapy, which includes vitamin K antagonists, otherwise known as warfarin. So what we know is the current indications include the reduction of ischemic stroke risk in folks that have atrial fibrillation, and those current indications include dabigatran, apixaban, rivaroxaban, and edoxaban, in addition to warfarin. We also know that they're indicated for the treatment of DVT and PE, otherwise known as venous thromboembolic disease. Again, apixaban and rivaroxaban have these acute indications, as do dabigatran and edoxaban, but they have to have a heparin lead-in to bridge from start to oral anticoagulation. Additionally, they also have the indication for post-surgical prophylaxis, mainly for hips and knees. That's dabigatran, apixaban, and rivaroxaban. The prevention of VTE in medically ill patients, largely hospitalized patients, is betrixaban. That was approved recently, and rivaroxaban is undergoing a phase 3 study currently. And what does the future hold in this space? We know that secondary prevention of ACS and embolic stroke of uncertain source is also an opportunity for oral anticoagulation, as well as thrombosis prevention in heart failure and in peripheral arterial disease. What are the next steps, particularly in 2020? What are we going to see in the next coming years? Well, we know that the DOACs represent a strategic advantage over current standard of care, which is warfarin. They're at least non-inferior in terms of their efficacy, but they have an improved safety profile, particularly with respect to ICH among elderly patients. Now that we have reversal agents, idarucizumab and andexanet alpha, they have readily reversibility in the setting of major bleeding as well. What we also know is there's opportunity, given the safety profile and the net clinical benefit, to see the use of these anticoagulants in other disease processes, such as acute coronary syndrome, embolic stroke of uncertain source, improved outcomes in PAD, which is peripheral arterial disease, as well as the reduction of VTE in hospitalized patients. And finally, where do we know about the data with respect to the oral anticoagulants, vitamin K antagonists versus the NOACs? Well, we know in atrial fibrillation, they're at least as effective, the DOACs are, to vitamin K antagonists. Where you really see an advantage is with major bleeding, particularly ICH in the elderly. And with respect to VTE, the DOACs are at least as effective and at least as safe in major bleeding. So what we see here is a slide depicting some of the pharmacology of the available oral anticoagulants. And for emergency physicians specifically, I would like to draw your attention to the half-life, particularly with warfarin, which has a half-life of 40 hours. And compare that to the novel oral anticoagulants, whose half-lives are quite a bit shorter, anywhere from 12 to 13 hours, which really plays into how we manage bleeding in this patient population. Additionally, I'd call your attention to the renal elimination, which goes to the renal dose adjustment that you might see in some of these agents as well.
Well, Greg, thank you very much. That's a great summary of these new agents and new agents compared to warfarin. And for our audience, this is going to be something that they're no longer novel. This is essentially mainstream therapy that's being used and requires the emergency physician, critical care physician, and colleagues to understand how these are used. And in particular, when you look at these various agents, and we will be discussing this in the future, is that they act at certain places in the clotting cycle. And so warfarin is one of those agents that causes large-scale blockade of the factors. And that's something that you get very much a surgical strike with some of these newer agents, such as dabigatran, rivaroxaban, apixaban, that strike at various very specific places on the clotting cascade. Thank you very much for watching MCREG International on the Go.